Hello, good evening, and welcome to tonight's conversation. I must apologize, we were unable to do this live chat during the day. I think today was one of those very busy days at the clinic. So, as you are joining us, please tell us where you're watching us from. And tonight, I am not alone. I'm joined by a guest. My guest tonight is an infectious disease specialist. He's also a physician like me, but with a special interest in infectious disease. So he went further to study infectious diseases. So we will have a very exciting time tonight to discuss a very interesting topic. And the topic of discussion tonight is discordancy or discordant couples with regards to HIV. Now, discordance or discordant couples, these are couples where one member in the couple has a given infectious disease and the other one doesn't. And tonight we are focusing this issue on HIV. We have people out there where one partner is HIV positive and the other partner is negative. How do they live their life? And to help me discuss this very important topic tonight, I am joined by none other than Dr. Francis Mupeta. Most of you know him, but we'll also allow him to introduce himself. Dr. Mupeta, how is Lesotho, my brother?
Lesotho is very cold. This part of the world, it's out of the tropics, so it's mostly cold. So it's freezing, I should say. Yeah, but
Wow.
otherwise, I'm all
Wow.
right.
So you're getting all the cold wind from the South Pole.
Yeah, imagine from the Cape of Good Hope, which is nearby.
Wow. Wow.
Yeah.
No, Dr. Mpeta, quickly, just give us a background of who you are, introduce yourself. I mean, there could be some people who are meeting you for the first time. We have people who are watching us all the way from Cameroon and different parts of Africa who may be watching us for the first time. So please just go ahead and introduce yourself fully so that everyone who's listening, can follow the conversation tonight.
Yeah, so my name is Francis Mpeta. I'm a physician, consultant physician, and I'm also an infectious disease specialist. Primarily, I work in Zambia at the University Teaching Hospital under the infectious disease unit. At the moment, I'm consulting with the World Health Organization in supporting countries towards the fight, against COVID. And this is basically just trying to set up systems, for case management for COVID and advising different governments, African countries on how to manage COVID cases, developing guidelines, experience sharing and best practices so that we learn together through, this pandemic and try to see how we strengthen the response. As you know, Africa is known for its weak systems, but it's only Africans who can strengthen the systems. And I think it has been realized at a global stage that this is what we need to do. And we need to ensure that our countries are able to respond based on the best current evidence and the best current, practice. So basically, that's why I keep on hopping from place to place, and including in my country, this is what we are doing. Thank you very much.
Thank you, Dr. Mpeta. And like you've rightly said, Africa is currently, and the globe, the world at large is currently faced with the COVID-19 pandemic. But tonight we are discussing a different pandemic. This is HIV. Now, before we get into discordant couples with regards to HIV, where is the Zambian? Can you paint for us as a way of introducing the subject? Where are we with regards to HIV in Zambia? What's the current scenario with regards to, where are we with regards to prevalence? Where are we with regards to treatment options? I know that treatment options for HIV have really changed in the last few years. So where are we with HIV in Zambia? What's the current scenario?
All right, so Zambia is one of the few African countries that has done extremely well with regards to HIV. management. Where we're coming from, the prevalence was quite high, over 20%. But now we have managed to control the HIV to about 11.3. It's not really where we aspire to, because ideally we are supposed to be in the elimination phase, where we, get the prevalence of at least less than 2%. But with regards to treatment, I think we have done extremely well. Out of the estimated 1.2 million, people who are HIV infected in Zambia, we have put at least over 90%, of those. First of all, we have identified 90% of those that are infected. And then out of, those who are infected, about 1 million, we have placed over 90% of those again on antiretroviral treatment. And then 90% of those on treatment are actually virally suppressed. So these were the targets for 2020, and Zambia was one of the few countries to attain the 1990 targets set by the UN AIDS agency. So we are among probably about 5 African countries that have attained that. So we are looking forward to the next targets by 2030, which is 95, 95, 95. And I think we are on course in attaining that. And if we are to attain higher percentages than the 95, 95, 95, we should be looking at eliminating HIV within a generation, and which is actually everyone's dream and the goal for the sector, that we eliminate HIV.
Right. Now, when you talk about HIV elimination, what are the strategies that what's the thinking around elimination? Because when could you just bring our listeners up to speed on how HIV is going to be eliminated?
Yeah, so HIV is going to be eliminated by just certain fundamental principles. Number one, we have to know, first of all, everyone who is infected with HIV. We have to identify each and every one of them. And then once we identify them, we have to actually now prevent them from passing on or transmitting to others. And how do we prevent? It's by actually placing them on treatment. And if we place almost everyone who is HIV infected on treatment, then they lose their ability to actually transmit this infection. And it's not just a matter of putting them on treatment. We have to ensure that they remain and they are retained on treatment. And then they also are virally suppressed, where the virus is undetectable, because that's the only way that they are not going to transmit HIV, because HIV can only be transmitted from someone who is infected. So if we are able to identify this pool of people who are infected, we place them on antiretroviral treatment and ensure that they remain on treatment for a longest time, and then they are virally suppressed, then we know that they are incapable of infecting the next person. In terms of eliminating HIV in the newer generation, that is children who are being born, we have to really focus on eliminating HIV in pregnant mothers. So meaning every pregnant mother should be screened and tested for HIV. And if they are found to have HIV, then they should be placed on antiretroviral treatment so that they are virally suppressed, and we eliminate the chances of them transmitting the HIV infection to their unborn children or to their newborn children. And that way, we eliminate both HIV in the existing adult population and also in the newer generation of children. So this is something that is attainable, and I think as a sector we're making tremendous efforts in ensuring that this is achieved. So I should not. I think there should be a connection problem from Dr. Mtijati's side. But yeah, so basically these are some of the things that we should employ. The other methods are the ones that have already existed. That is, number one, ensuring that we prevent those people who are not on antiretroviral treatment from passing on the virus to people who are uninfected. And this could actually be promoted for young adults and children abstinence, that is, delaying and actually, encouraging them to stay away from, sexual activity. And then for those that, are young adults, adolescents, and those that could not manage, then we have to promote the use of, condoms, which are actually very effective at promoting, HIV. Then now we have got the newer methods of prevention of HIV infection, and these are, based on treatment as a prevention modality. So this is where if you are at risk of acquiring HIV, then you are put on antiretroviral treatment to prevent you from acquiring the infection. Should you come, in contact, or should you have, sexual activity with another person who is HIV infected and who may not be suppressed. So this is, another way that we prevent HIV in the people who are not infected. We also look at, post-exposure prophylaxis. And post-exposure prophylaxis, this is where if you happen to have, an encounter, sexual encounter, or any other encounter with a high risk of HIV acquisition, including needle stick, victims of rape, defilement, then you are put on, treatment to prevent you from developing, HIV infection. So this is called post-exposure prophylaxis, PEP, and it happens after the exposure, whereas pre-exposure is where you are put on treatment before you are exposed to, a high-risk event, such as, sexual activity, especially among discordant couples who we shall be discussing today. I think we seem to have lost Dr. Mjajati. Who we shall be discussing today. Okay, so I think I'll try to go on until Dr. Mjajati gets, reconnected. I think we seem to have lost Dr. So yeah, we were talking about, strategies that we can use to eliminate. Now, in the area of prevention, I should mention that there's been quite an advancement, especially with, the modalities of prevention, and this advancement has mostly, occurred in the PrEP. So much that we have had, different types of, prevention strategies in this area. So I will talk about first, in 2020 and beyond, even this year, with our women folk. Sometimes most women do not have the power to negotiate for safer sex, especially, where certain men seem to be in an advantageous place. So there is what is called a ring, a vaginal ring, which is impregnated with dopavirine, which is an antiretroviral drug, and this drug is able to prevent, acquisition of HIV by the female if they happen to, be exposed to HIV infected partner. So this is, it's in the guidelines in the Zambian HIV prevention and treatment guidelines, and it should be rolled out soon, and it should be available. Efforts are also being made to ensure that these rings could actually, be used as also a contraceptive, so that you get a double benefit of HIV prevention and also a contraceptive. So very important that people look out for this, especially our female folks, and including male folks, those who have been, to be infected, and they wouldn't want to pass on this infection, to their partner. Then for the rest of the population, including males and females, there's a pill which is given every day in the name of Truvada, where as long as you remain exposed and you keep on taking this pill, then it will be able to protect you from acquisition of HIV. I should also mention that what is in the pipeline also from this year and probably beyond, and we hope that it shall be in Zambia, is where you are going for an injection just once in a while, and the current one is where you go for an injection every 2 months. This is similar to Depo-Provera among our females as a contraceptive, where every 2 months they get a jab and they are able to achieve that contraceptive effect. Equally in the HIV field, we have injectables that are coming where for every 2 months you go for an injection, and it should be able to protect you for that long. So we should be able to look out for this, and they should be really these are game changers, in that a lot of people could actually go on for these, and if they are high risk, or even when you're not high risk, but you never know the people that you have encounters with, and this will be able to protect you from having or acquiring HIV. So this is very important that people look out for all these preventive measures, and if taken together, the preventive measures, the screening, testing, and treatment, then we are looking at eliminating HIV in our lifetime. And the antiretroviral drugs and these strategies are highly effective at preventing HIV acquisition. So Dr. Jajati has informed us that he is going to join later. I think he's having some issues with the network. So we shall continue. So the topic for the day is to talk about discordant couples, and Dr. Mjajati had attempted to define what discordance is. So discordance is basically, different, not in accordance. So you have a couple, which is two people, where one has got HIV and the other one has got no HIV. So this is called discordance. So this actually occurs in Zambia and across the world. There are so many couples who have found themselves in such a situation. Now, initially or in the years past, because of stigma, the lack of proper medication and poor information, to find such a couple, it led to a lot of divorces, a lot of stigma and the misunderstanding because of just the myths and so many information gaps with regards to discordance. Now today we should be able to actually live fulfilling lives even when somebody is in a discordant marriage. So it is very, very important that we understand this. So let's start with, how does that situation happen? How does people find themselves in a discordant couple? So one, it could be that by the time two people are becoming one as a couple, one was already infected, or during their union, one becomes infected, but the other one remains uninfected even despite being exposed to the infected partner. So we look at three things that actually can lead to this. Number one is the human factors that can result in such a situation. And then the second one is actually, the viral factors. Okay, so basically two things. Now, if we look at the human factors, we will dissect it at different levels. Number one, it's about exposure. Okay, so if somebody is uninfected, they have got an infected partner, what is the exposure between the two? Do they have frequent, sexual intercourse? As you know that the risk of HIV transmission by vaginal insensitive patient act is about 0.3%. So the higher the exposures, the higher the risk of getting HIV infection. So if we look at the number of sexual encounters that they have, especially condomless encounters, then this patient is at higher risk. But if this couple rarely consummate their marriage, then the risk becomes low for one who is uninfected. So that's number one when it comes to exposure. Two, the consistent use of barrier methods, such as condoms. So couples who use condoms, actually, even when one is infected, the other one is not, there are very little chances in passing on the infection to an infected partner, because condoms are very effective at preventing HIV. So that's one of the reasons why these couples could be. The other one is despite people not using condoms, despite having frequent sex, the other reason could be genetic makeup of certain individuals. There are certain individuals who are born with a certain type of gene that prevents them from easily getting infected with HIV. This is seen in Western Europeans, and it's also seen in a few African individuals, especially those from Kenya. And studies have shown that some prostitutes in Kenya, despite frequent, condomless exposure to people who are infected, actually did not end up getting HIV infection. So this phenomenon has been known, and it's because certain people are born with a certain genetic, makeup that makes them resist the HIV infection. However, these are very rare, genetic systems in African population. But in an in European population, it goes to up to about 10% of the population have got, that strong gene that makes them resistant, and in about 30 to 40% have got some form of resistance, though not fully resistant to HIV infection. So such, happen. Then the other human factor, we'll go now to the viral factor. Now, the virus itself, all right, if the person who is infected is not on treatment, their immunity is low, there's a high chance that they can easily transmit that virus to the next person. So if you are in this marriage where your partner is not on treatment, it means that their viral load is very high, and the risk of contracting HIV is also very high. And all those who are HIV infected and they have got a low CD4 as well, they also are high risk, of transmitting to their partners. So those are some of the immune and genetic makeup. The other one is certain viruses are rendered weak by exposure to treatment. So you find that it loses the ability to effectively infect the next person. So if such, a person has been on treatment for some time, they may develop such a type of a variant. And I'm sure by now people have learned of variants because of, COVID, where we are seeing variants popping up here and there. So even with HIV, the HIV virus, mutates, and variants keeps on popping up. So certain variants, they lose the ability to easily infect the next person. So you find that if such occurs, then the uninfected partner will not get infected, because the virus that is in their partner is a weak one and cannot easily transmit. So those are some of the reasons why we experience discontents when it comes to HIV. And then the other thing I wanted to also emphasize is the immunity of the person who is not infected. Some people have got better immunity that will be able to resist the HIV, but basically it will go down to the genetic makeup that makes somebody to be resistant. Okay, so I think I've spoken alone, and Dr. Mjajata, I think, is coming up. We lost you.
Doctor,
We are glad you are back.
You see, this is what happens. I didn't charge certain gadgets, so the thing just went off on me. We're going to proceed, but I'm glad you continued. I was getting worried that you might stop talking.
No, no, no. I continue. So we have looked at despondency itself. We have looked
Yes.
at how do people become despondent. Then I
Mhm.
also finished off the previous question on elimination of HIV. So we looked at the screening and identification of people who have got HIV. Then we looked at the preventive measures, and we also looked at treatment for prevention, and also just treatment as way of eliminating HIV. So we
Right.
should be able to pick up on discordance. We have explained how people can become discordant couples.
Right. So now I'm going to step away again, but I need you to continue on to talk about how does the HIV negative couple remain HIV negative, and I need to talk about how can they then have children if one is HIV positive, the other one is HIV negative. How do they have children? And also, when the child is born, how do you know that this child is actually HIV negative and not HIV positive? And how does the other partner ensure that they stay negative? So I'll step away again so that you can explain in detail to our followers on that. Let me see what else I can do in the background to sort out my technical issues. But continue. I'm also listening. I'm following, despite these technical challenges that we have. But like we don't stop despite the challenges that we face. We'll find a way of getting around them. So answer those two questions. Don't You are not alone. I'm still here with you.
All right, thank you very much, Dr. Mjajati. So, the surest way of discordant couples remaining discordant is not to take chances. So, first of all, the infected partner should ensure that they are on antiretroviral treatment, and they should be adherent to the antiretroviral treatment, taking their treatment every day, and that will result in their viral load being suppressed. Now, a person who is HIV positive and is consistently on antiretroviral treatment, and their viral load becomes very low to the point where we can't detect it, a condition we call undetectable, that makes them reach a state where they are incapable of transmitting the HIV to the next person or to their partners. So this is where the concept of undetectable is equal to untransmittable came from. You is equal to you. So if we are to have all HIV positive people, persons on proper antiretroviral treatment, and they have suppressed viral load, then it's possible to eliminate HIV, on that phase. Now, because we are human, all right, there could be a day or two when you actually forget to take your drug, or you forget to take the drug on time, meaning it gives the chance for the virus to replicate and increase. And then if you happen to actually have a sexual encounter with with your partner, the one who is not infected, then you are putting them at risk. So now there is now a movement not to focus on the people who are uninfected, but to also look at the uninfected partner, so that we don't leave them to live by chance or by the mercy of God. So we also now have devised methods apart from using a condom. As you know, most couples find it very difficult to use condoms when they are married. We put them on treatment for prevention purposes. And this is where I said for females, there is a vaginal ring which you insert inside the vagina, similar to the way you insert the ring from the female condom. And this is able to stay on for some time, about 7 days to 30 days in some of them, and it should be able to protect you even with condomless exposures to your infected partner, regardless of their viral load or CD4 counts. Now, for other people, males inclusive, and even females who might not be comfortable in inserting, a ring, then they can actually take a pill every day, as long as they are exposed. Now, I want you to listen carefully, because this pill a day only becomes effective for males if you have taken it, for 7 days. Then after that, it has become fully effective, and then you'll be protected. For females, however, and unfortunately, for them, it requires for you to have taken the pill for at least 21 days before we can say that you are fully protected to have, high risks, sexual encounters by taking the pill. And again, you do not have to stop it immediately after the exposure. You have to at least continue it for 7 days since the last high risk exposure. Now, if you are married or your partner lives with you, then you have to be on, PrEP for forever, as long as your partner is still, existing. Now, there are circumstances in which we can recommend that you stop PrEP. And I think I'll take this opportunity to encourage such discordant couples to visit their ART provider, who can explain more, as there is risk of people misunderstanding if I was to take that route here. So that's how discordant couples will remain discordant, where the uninfected is not going to get infected, a situation where we call seroconversion. And like I said, I preached a message of hope that soon, from the daily pills, we are going to actually eliminate that and replace them with an injection, where you just get a jab once every 2 months, and indication that in future there that these jabs could be reduced to just about 2 in a year. There was a question from somebody on the chat saying, are these daily pills safe in people who have got other medical conditions such as diabetes, hypertension? Yes, it is. And any person who doesn't have HIV but is at risk of acquiring HIV from their partner or by virtue of their profession, such as commercial sex workers, they are encouraged to be on PrEP. And it's either the daily pill, or the vaginal ring for females. So these are the proven methods of how we should help these discordant couples. Now, when you have got such a couple, then they will be at liberty to actually even try to conceive, because the infected partner will be virally suppressed, either the man or the female, and then the other partner will also be protected via PrEP. So, meaning they should be able to, conceive. Now, it is important, if it's the woman who is HIV positive, that they are actually virally suppressed through and through the period of pregnancy, because then it means we eliminate the child being infected whilst developing in the womb. And then during postnatal or post delivery, we also put a child on some form of PrEP, now for children, for infants, and that child will remain to be on PrEP until the risk of exposure is eliminated. And the exposure to the mother is mostly through breastfeeding. So women who are HIV positive, who are on antiretroviral drugs and are suppressed, can safely breastfeed their children and replace those children on infant prophylaxis, so that we prevent them from acquiring HIV throughout pregnancy, at labor and delivery, and also postnatally during breastfeeding. So that's the proven way. And if you look at where we are coming from, pediatric HIV transmission in pregnancy was about 5 to 10%. So, meaning out of the 100 pregnant women with HIV, about 10 children or infants will be born with HIV. And then this risk became even higher during labor and delivery, where some children will be infected during that period up to a tune of 25%. So meaning out of the 100, about 25 will be infected during delivery. And then the other, 10 to 15% will be infected during breastfeeding. Now, if we look at these figures, these are very, very high risks for our infants. Now, with effective treatment of HIV in pregnant women, where we place all HIV pregnant women on antiretroviral drugs, and also administration of prophylaxis in the infants, we have seen a reduction to less than 2% in most instances, and the goal is to reach less than 1%, and then we'll see that we are going to eliminate HIV in children. So these are very effective methods. They are safe both to the mother and to the infant, and we have seen multiple studies showing that the risks that initially were thought of are actually not something that happens, and therefore we should be able to have children free of HIV and then free of effects from the drugs. Then the other question I think, Dr. Mjajati, you left is, how do we know a child who is born is not HIV positive if they are born to HIV positive parents? So HIV in children could be because both parents are HIV positive or because the mother is HIV positive. Now, how do we know that this child who is born? So like I have said, if the mother has been on antiretroviral therapy and the child is born, and then if the child is breastfeeding, we put them on prophylaxis, then we know that there is hope that this child won't be infected. Then there are certain tests that we do, very sensitive tests, which we normally don't use in adults, where if the child is born, we do a nucleic acid test or HIV DNA test. So if at birth it's positive, it could be that the child was infected, before in pregnancy, or it could be because of the maternal or the mother's infection. So that one does not worry us much, and especially if the mother had received sufficient, had received antiretroviral for a sufficient period. So then we repeat, this DNA test or the NAT nucleic acid test at 6 weeks, and also we repeat at 6 months. The guidelines now have changed towards doing up to just 6 months. Then thereafter we look at the high risk exposure, where we do other tests, especially those who breastfeed beyond 6 months. Now these tests, like I've said, they are very, very sensitive, and if the child doesn't have HIV and they successfully weaned off breastfeeding, they had received adequate prophylaxis, there's a very high chance that this child actually will be HIV negative for the rest of their lives. The risk is very minimal of HIV infection after you institute these measures in a tune of less than 1%. So we can see that they are very, very effective, including the tests that are being done.
Now, there's a question here. Dolutegravir. Apparently, there's a question here to suggest that dolutegravir may cause brain damage in children. Could you just comment on that very quickly?
Yeah, so thank you very much. So there was that fear when dolutegravir was just introduced in 2014. And this fear actually came from one of Zambia's neighbor, which happens to be Botswana. Now, this phenomenon was not reported anywhere else in the world. So there was that, the scientific world is a very sensitive world, and we actually, as doctors, we take Hippocratic oath where we say do no harm. So it had to be, paused because of a caution. Now, after looking carefully at the data, it was found that the women who received dolutegravir and those who received other antiretroviral drugs and those who are not HIV negative, actually after following up those children that were born to such three categories of women, there was no difference in terms of the neurotube defect in children whose mothers received dolutegravir or in children born to mothers who had received other antiretroviral drugs other than dolutegravir, or mothers who did not even receive dolutegravir. So this now has been shown that it's actually not linked to dolutegravir, but it was an event that occurred in the population among the Swana. We have given dolutegravir to a lot of pregnant women in Zambia, and we haven't seen such cases coming up as a result of them being exposed to DTG. So DTG does not cause children to be born with neurotube defect or what people may call brain damage. It doesn't. It's very safe both to the unborn child and to the mothers.
So there's a question from Fletela Lungu. His question is, how does a growing child in the womb get HIV?
All right, so number one, if the mother has got HIV and is not on antiretroviral drugs, it means that they have got a very high viral load that puts the child at risk. So that's number one. Two, during birth and delivery, the child, the mother, the placenta, there's blood. The child could be exposed to the mother's blood, and that's how they can get infected. The third one is through breastfeeding, because HIV can actually be expressed in breast milk. So those are the 3 points at which a child, unborn child and eventually born, could actually be infected with HIV.
Right. So, Dr. Mpeta, as we come to the conclusion of this topic, I know you're coming back tomorrow for another very exciting topic, and I'm just preempting that tomorrow will be here again, most likely in the evening, to discuss another topic. So, with regards to the issues of discordancy in HIV, what is your final message to the listeners?
Yeah, thank you very much. So I think we have moved from an era where we used to look at HIV as a death sentence. HIV now is very manageable, and HIV-infected persons, whether they are discordant or not, can actually have a child who is free from HIV. And this is largely attributed to the advancement in the treatment and care of HIV-infected persons. So if you have got HIV, or you are in a relationship where one has got HIV and the other one doesn't have, you don't have to stigmatize your infected one, and neither should you be afraid to leave your full productive potential, that is to have a child. Because all you need to do is get in the HIV clinic and speak to the ART provider, who are going to guide you and prepare you for the conception of your child, and then will also manage you throughout pregnancy and breastfeeding until such a time where we know that the child is no longer at risk of being infected, and then we'll definitely discharge you. But otherwise, it should not scare anyone, whether HIV positive or not, whether one is HIV and the other one is not. Everyone now has got a chance to live a fulfilling reproductive life and having a child, who is HIV free.
Right. Thank you, Dr. Mpeta, for joining me tonight, and I'm hoping that we can make time tomorrow for another very exciting topic. And good night, and I hope you stay warm in Lesotho. Like you rightly said, it's very cold out there. And thanks for joining us.
Thank you very much for inviting me. Good night.
There you have it, ladies and gentlemen. Tonight we're discussing discordancy in HIV. As usual, like we keep asking you to do, please share this video as widely as you can, because we need this information out there. Once again, apologies for the technical glitch that I had earlier. Tomorrow we'll just make sure that we put everything in order. So please go ahead and share this video. Click that share button. We need this information out there as much as possible. So until tomorrow with another exciting topic, we may have a few more guests tomorrow to discuss the topic, because it's quite an interesting topic. Good night and look after yourselves. Remember to drink water and brush your teeth before you sleep. Do take care.